It has to hide.
No, I'm just trying to
Grab your extra. Trying to read.
There's water in.
How about here?
So it's a little crazier than normal.
Getting crowded up.
For you, you weren't here for class.
Ooh,
What's
I
that?
love that. Really quiet.
So last night, Wednesday night, so probably next Wednesday
The
night,
other thing that was
coming home from the
not
Rural Health
quite
Conference.
planned was my daughter and I.
You're gonna be there, right?
We're driving. I'm driving.
Oh, okay.
We just like it. And we had decided of all the time.
I'm glad you're gonna be there.
Yeah. Have a
We
bunch
have-
of staff on going. So,
Yeah, well, this was our day.
We have, yeah, you know,
Right by me.
Greater Columbia keeps getting called out as like the all-star workforce, you know. And only because Suzanne knows that we do what we do. But,
oh
so
my
the
gosh, I
academic
can only
partnership,
imagine.
the academic community partnership session has more people registered in that session than any of the other Wednesday afternoon.
All right.
Yeah.
Neither one of us could take it anymore. I thought I would be
It's
happy
that-
to forfeit these.
I'm the MC, I guess, for that
So we
session.
went back to the conference room.
Maybe it's just you, Dan.
And that was such a. Look at all of those.
So Diana,
Oh my goodness, I can't even imagine.
from the AIM Center, are you going to be going up to Spokane or Seattle for one of those?
Yes, she wanted me to do the one in Spokane. In the beginning of April.
Would Sandra actually be on the panel?
Be there. I know I can.
Are you on the panel?
We'll be able to make it.
Yeah.
Because I'm on the panel.
I'm pretty
I think it'd be good for you to be on the panel.
I wouldn't have thought about
Let's say
that.
Victoria and I.
That would be mine.
I don't really care.
So I've also asked Jeff Thomas from Frontier Behavioral Health to be on the panel. And that's why I was talking to Brian.
That's probably what my was when I was in bed, but like,
After the- I said,
it's like, St. Patrick's is not a
We've got to
very
get
big
the people that are in the trenches doing the work
Oh my
with
goodness.
some kind of reality checking on with the reality checking with the AIM Center.
Yes, I know.
Okay, is everybody ready? We have a full table. I suspect we have a quorum.
Yep.
I see Julie on the phone, so I think we're going to call this meeting to order. We can. So let's go ahead. So let me just say welcome, everybody. Welcome, everybody. Happy spring.
Yay!
Hopefully nobody had to do any shoveling this morning. Said that on Tuesday and it didn't cause snow to fall. So hoping that it will cause that again today. So let us start with introductions. Rhonda Hoff, Yakima Neighborhood Health Services, Chair of the ACH Board and representing the housing sector, and we'll go counterclockwise today.
Dan Ferguson with the Allied Health Center of Excellence, hosted at Yakima Valley College, representing the workforce development sector.
Lauren Johnson, Greater Columbia ACH.
Madeline Carlson with People for People, representing transportation and board secretary.
Jorge Rivera with Molina Healthcare of Washington, representing the NCO set.
Lisa Landman, board vice president and representing public health. And I brought Ashley Walker as a WSU student, interning at my Garfield County Health District, so she's just riding along with me today instead of two cars. We're a single coordinated care observing. Go Tar Heels. Caitlin Stafford with Mary Group.
March Madness already?
Yeah. Oh, today.
Yeah.
Okay. I'm with you.
Caitlin Stafford with the Mary Group. Ashleen Fernandez with Greater Columbia.
Martin Sanchez with Greater Columbia.
Jenna Shelton, Greater Columbia. Carrie Green, Three Rivers Community Foundation, representing philanthropy. Go Zags.
Carol Moser, Greater Columbia.
Sandra Suarez from Yakima Valley Farmers Clinic, representing FQHD.
Atlas Community Health Plan of Washington, Missouri. Sarah Foster.
Ronnie Bachelor, Lord, we are Lord, Healthcare, and, mobile outreach team, representing Boomer today.
I'm Dana Otis with Lord's Health, representing behavioral health. Sam Madone, Greater Columbia.
I'm Les Palmer from Education Service District 122, and I'm here for education.
Patrick Constitution, Washington University's Public Policy Institute and informal historian of the ACH.
Patrick has many roles. Les Lucky, Greater Columbia.
Rita Vance, Greater Columbia.
Ruben Peralta, Greater Columbia, go Flume, say no, and not.
Good for you. Diane Halo, Greater Columbia. Jesse Coleman, Greater Columbia.
Well, Sabin, where am I at? PHPW.
And on the phone, I see Julie.
Julie Peterson, from Kittitas Valley Healthcare, representing hospitals.
Thank you.
Susan
And
Grando, Social Service Sector.
Thank you, Susan. And do we have anyone else on the phone?
Rhonda. I'm sorry, you just had Courtney logged in too.
Oh, thank you. Tanya?
Oh, Tanya Cruz with the accommodation.
Did somebody just come in from that direction?
Sonia.
Hard to keep track.
Yeah, no, I just opened the door. Okay, so is there anyone else on the phone that hasn't introduced themselves? Okay, so thank you all for being here. We start each agenda with asking everyone to reflect on the attestation of conflict of interest and self-dealing transactions. There's a refresher and take a glance at the agenda. If either now or when we get to that agenda item, if you feel you have a conflict of interest or self-dealing transaction, please bring that to the board's attention. On the consent calendar, we have the minutes from February 21st meeting. And that may be the meeting that I wasn't at. So, hopefully you've had a chance to review those, and if so, I would ask someone to make a motion to approve.
I make the motion to approve. Second.
Second by Madeline.
Madeline. Who motioned?
Is there any
Thank you.
discussion about the minutes? If not, all in favor?
Aye.
Anyone opposed? Any abstentions? That would be me. Thank you. Okay, so I think we're on to the report and update. So Carol and staff.
So why don't we just do the updates as they're listed here, and then if you also have something that's written in the GCACH report, you can report on that at the same time. So I guess we'd start with Diane.
Okay. So we have the RFP that's out. I have received 0, but I have had confirmation that there are 3 coming in today.
We do.
Tomorrow.
So can you tell me what this RFP is about?
The RFP is for we brought it to you guys.
I know, but I just,
okay.
I need to read
It's for a resource network manager. And basically the resource network manager is going to be like the hub. And then we're going to partner with all of our partner providers to get involved with the opioid crisis and on board with that. And then also we have one of the things that's in the GCACH report is there's actually 2 things that are in here for me. And one is the summit that we're having, the trauma and opioid summit that is going to be in Yakima.
Do you have to say the date card?
Yes, and if anybody doesn't have a save the date card, I have some still. So, you know, I think everybody mostly has one in here, but I think Terry and a couple of the other people on that side. So we'll go over this. Basically, we have a really great lineup. We have a 4-track series, and we have 60 speakers. There's 4 of them right here
that are on there, and I was able to go to and then also if anybody wants to be a sponsorship, I have the sponsorship forms that I have, you can send out. And then the sponsorship, includes free admission and then a table for this and also some other things as well. And then also, if you don't want to do a sponsorship and you just want to do an exhibitor, then you can do an exhibitor and have your table there, have a table representing your organization, and what you can provide flyers or whatever. So those are the two options. And then also you can participate. And then the website will be coming out soon. The prospectus is right here on the thing. It's been sent out to you guys. Let me share that with the prospectus. But the website for the registration will be coming out hopefully within the next week or so. And so we will send that out to everybody. There's only 300 spots, so hopefully everybody who wants to be there will register quickly and be able to get their registration.
And how much is it to register?
It's $150 and $50 extra for CID.
So just back to the article. If I remember right, it's specific to Benton Franklin County
And Walla Walla.
And Walla Walla. And the Department of Health had issued grants for a hub and spoke model in other parts of the state, and so this sort of replicates that. And Benton Franklin and Walla Walla were not communities that received them.
Right.
And so this would put that model of the hub and spoke, and so the RFP is for the hub. Is that correct?
Correct. And then it's about a year long, and then we're hoping that hub can help train the PCMH, and so that maybe then that way we can organizations will be able to keep kind of their own. So we'll see within a year if it's working or if we need to extend it. It kind of depends on how it works. Yeah, so it's for the 3 counties, and the only one that was awarded was in Yakima in our area. So that's why we chose Walla Walla and the Benton County and Franklin County, because we had the highest amount of issues.
So the ORA in Yakima actually extends up into Kittitas and over into Sunnyside, so it's a little bit broader than that. But the RFP that we put out, I mean, to some extent was plagiarized.
Yeah.
To follow
We
the
use a lot
statewide
of
one,
yeah.
which is fine, if we want to be consistent with that. And as we talked about earlier, we also hope to have the health commons linked up with this as well, because referral management and care coordination is absolutely essential for that particular population, which is very high risk.
The one difference that the hub and spoke model and our model has is that the MAP provider with the state hub and spoke, they had to be a MAP provider. In this, in RFP, we are letting the hub be a partnership with MAP provider, so they don't necessarily have to be a MAP provider themselves, as long as they have a collaboration with somebody that is a MAP.
It has to be either they are or they have a partnership. There's no third option.
Any questions from anyone?
So the next update would be the status of the Yakima Nation LIN and MCP project. So you might recall that at last meeting, the board discussed about the need to establish a local health improvement network just for the Yakima Nation. They have 29 programs, and they weren't really being able to access some of the funding that the LINs are receiving. So with that knowledge, I met with Arlene Washington, who's the deputy director for the nation and oversees all the programs, and he was very interested in becoming a LIN. Their program managers meet monthly anyway, so we're going to continue that conversation on the 28th. And also, just last week, Ruben and Wes and I met with Rob Arnold with some of the program managers of the Yakima Nation to discuss interoperability and IT. The GCACH program is another option for the Yakima Nation. It ran into some obstacles with CMS, and so CMS sued the state because of the GCACH program, because it excluded people that were not tribal members from receiving the services, the DHAT services. There has been legislation, though, reintroduced this year that I think helps resolve some of that. Still, the training is currently in Alaska, in Anchorage, so maybe we can circle back. We did identify early on with the Yakama Nation, though, a huge need to be able to have their program managers talk to one another, which they aren't able to do. So we're hopefully going to be able to advance that project, and I think we're meeting with them on April 3rd. I guess I'm the next one, the status of the Supporting Housing Summit. So several of us were at the Supporting Housing Summit. Thank you to Rhonda for being one of our presenters. Unlike Yakima, Benton and Franklin counties does not have an established supportive housing group. They have a continuum of care group that meets in conjunction with Benton Franklin Human Services, but they have never really, I think, formally addressed supportive housing needs. And so we're testing out, how do you put one of these things together, and had a really wonderful summit on Tuesday with over 90 people attending to hear from Rhonda, who talked about their model of supportive housing. Rob McCann, who's the CEO of Catholic Charities in Spokane, came down and spoke about his model. And then we had a data presentation, a very extensive data presentation from Patrick, looking at meta research and other research around supportive housing and some of the outcomes. And then Lisa Lauren, who was from AmeriGroup, and gave an excellent presentation on the third initiative of the waiver, which is long-term support service. Yes, long-term support, supportive services and employment. And I think the thing that was really interesting about her model is that there were several providers in our area that are not taking advantage of this, of these waiver opportunities. And I think that it's also another way to help leverage supportive housing services in Benton and Franklin County. So I thought it was a great forum. We probably didn't allow for enough time. I had to kind of cut off Rhonda a little bit short, but I think the proof of the concept of the ACH was really in play when, after the meeting, you saw these groups of people that were gathered around talking to one another, just networking, and brought a tear to my eye. First Kat, to see Rob McCann being surrounded by a group of the fire chiefs and the police department, and that's really what the ACHs are meant to do, is to convene and help these groups integrate their services and their programs and assist one another in solving complicated problems. And certainly homelessness is really a complex problem. And until we solve that, we're probably not going to see a lot of reduction in our emergency department utilization rates, our EMS calls for service, because these people are typically pretty high utilizers of those services. And so it's really important that we link some of these social determinants of health with our medical services and the providers of these services. I think that it was shown that depending on which model you look at, I think that there are cost savings in the system, maybe especially in some local government sectors. But we're hoping to duplicate this if it's successful in other areas, because, as you recall, housing, I think, was identified in almost every win as a high need. So if we can help start addressing supportive housing in other areas using either Rhonda's model or Rob McCann's model, or a combination of the two, I think we'll finally start to move the needle. But housing first, I've become a true believer, and the presentations I thought were excellent.
Do you have any plans to do that in Asotin or Whitman County?
I think we'd like to get a success story under our belt first, Martha, but certainly I know Megan DeBolt has already reached out to me because they want to do something in Walla Walla. But I think we'd like to get a little bit of experience under our belt to make sure that this is how we can do it. And then, always circle back with Rhonda and Rob and figure out what's the best model in each community, because each community is kind of set up differently. But yes, the hope would be to be able to spread and scale that model.
So one thing that I learned, again, Patrick had a marvelous being the data person, a marvelous review of the National Academies and the RAND Corporation. And looking at his data, you kind of get a mixed view, but the way I interpret it is that the way you focus, the particular client that you focused on, really has a lot to say about the long-term outcomes as far as not only permanent housing, but also in terms of reducing utilization, as far as hospital utilization, ED visits. So in my mind, it makes sense to focus on those individuals somehow through a pre-op process or an intake process to get those people who do have some high cost, high needs, and try to get them into the housing first, and then connect it to support services.
You're up, Wes.
Oh, sorry, I was looking at the GCACH report. So we have had an ongoing conversation with Puneet at CSI. As we've talked about earlier, the implementation of CSI for our reporting portals is much different from what the other three ACHs are going through. And it's primarily because of this web form that practice transformation organizations will be inputting data into to meet their practice transformation milestone deliverables. Our goal was to get that up and running by the end of this month. That may or may not happen. In any case, we've had ongoing conversations about how to translate the toolkit and the accompanying workbook into a format that they can turn into a database. We've had conversations, I've had conversations, Sam has talked to me, and it's an ongoing process. So we're still in that phase right now of getting that set up. And as soon as it's set up, we'll put that online. And we've also talked about the landing page. CSA calls them communities. Some ACHs have 3 communities that are broken down by major project area. The ACH will have only one, so this will feed confusion about where do I go for specific information. In that landing page, there'll be directories there for each individual practice transformation organization, so they can get out their contract, their practice transformation implementation work plan, perhaps completed NEHAP, and other information. And those particular directories will be secure, so that when someone signs on, the system will recognize who they are and which organization they're from, and give them access, and only them. So again, that process is still in play, and we hope to have resolution and the site come up within the next few weeks, or hopefully within the next month. And again, if it's not ready by the middle of April, when the first deliverables are due, we have a backup in paper and electronic form. Anything else you want to add to that?
Covered it all. Any other questions? And has the board seen, what the workbook looks like?
The workbook?
Yes.
The board has, okay. Based on which groups have seen what.
I know.
So that's it. Does anybody have any questions about the portal, what its purpose is?
If anybody would like to see the workbook, please let us know. We can get that out to you right away. It's a Word document.
It's online.
Yeah, it's on our website too.
All right, Ruben.
All right. So last Friday, we convened the first AIDS Resilience Task Force. It was a very good meeting. We ran out of time, so we weren't able to cover everything, kind of like the housing summit. We completed the data review to pretty much look at our region and see where the hotspots are, where the highest need is based on indicators and population. So we kind of based on the data that was corroborated, we looked at the Robert Wood Johnson Foundation, the latest information we have, which Wes is going to talk about later on. And we also looked at some data based on school districts published by GCACH. So it looks like the Yakima School District population parks and school districts seem to be the hotter spots pretty much. So that to cover the data, we did not complete looking at the charter. So we didn't get to the point to where we start talking about strategies. So we look at the severity by region, by ethnic group, but we didn't get to talk about strategy so much. And we, like I said, we didn't get to complete the review of the charter. So we put together a subgroup, and we're scheduled to meet April 1st to dig deep into the charter and refine it. We're lucky that we have some very, very impressive people with impressive credentials to be part of the subgroup. Carla Kroc, she has been there on the ACES topic since the beginning. Kate Atkinson from Yakima, I think she's part of the ACES coalition. I forget exactly the name. People for People. And Terry Varela, everyone knows that name. She's the executive director of Community Resilience Initiative in Walla Walla, and also Ruben Alvarado, who's a board member here, and his community, the community he manages at Tierra Vida, they've done a lot of work around ACES. They've had the strengthening panelist group there, do several programs there. Grace Valle from the school district, her expertise is marketing, media. That's school district. That's school district? Oh, no, we have other school districts. Sorry, Paso School District, yes. Magdalena, she works with First Steps, GCACH, and there's Newsom, who we all know pretty much. So, and are you going to be in this suburb?
I was there. I was on the call from Las Vegas.
I'm naming the people that are part of this subgroup.
Yeah, that's right.
Yes, and we had 22 people altogether. Including Rhonda.
I'm sorry, I wasn't available.
That's a good one.
So yes,
Sure, really come back.
Sorry.
Sorry, Ron, I was naming the people that volunteered to be part of the subgroup. But April 1st, hopefully we get to really refine the charter based on the input from this very impressive people with very impressive credentials.
Some points, Dr. Studio Thunder, with some points that stuck out for me from the first meeting was, first of all, I think the group kind of moved forward taking a community-wide approach to this particular campaign rather than focusing on individuals, trying to use existing programs where it was reasonable, and focusing on protective factors and positive childhood experiences and supportive ways to build resiliency. So those are probably going to be some things that we touch on.
Pretty much build community resilience,
I thought it was a very positive discussion too, likewise. And I thought just from the last meeting, I don't know if it was discussed last meeting here, but the meeting before the board meeting, when that seemed to be the sentiment that we heard here too, which we really wanted to focus on resilience and protective factors rather than talking about the needs. Right. So I thought that was a really great conversation.
We didn't quite get to the point where we talked about strategies, and that's where that conversation. I think Martha has a comment or a question.
Was there anybody from Clarkson High School there? Was anybody from Clarkson or Sutton County there?
We had Sarah Myers representing your zone. I'm not sure if anyone from the school district.
Okay, just because you mentioned Clarkson as a hot spot, they do have a resilience group in Clarkson. There might be somebody else that from that group that would be interested.
I sent out an invitation. I never heard back from.
I'll work on it.
Could you give us a contact?
I'll work on it.
Thanks.
That would be great.
You want to talk about the tribal liaison meeting?
Oh, we're doing a report? Okay. Yes, we had an in-person tribal liaison meeting last year on the 22nd, and we're not on a set schedule for these in-person meetings, but we do have every 2 weeks we do have a telephone conference meeting, and this is for GCACH tribal liaison people to share what we're doing and how we're collaborating with the tribes within our geographic region. And so, we all met, and one of, the highlights I wrote here was the highlights of the meeting. There was a lot of, discussion there about the GCACH and the community health aid program, and Harold referenced the GCACH, earlier today. So that was pretty much the highlight of that I kind of took from the meeting, and we get some education, some cultural education there too, because we have people from different parts of departments from the state. So they help those of us who are not Native American understand the culture a little better, and that's pretty much the what I got from the meeting, and the purpose of these meetings, that we have one the bi-weekly telephone conference tomorrow as well.
So since, I know Becky and Rachel, you're going to be moving into the other report, why don't we hear from Martine and Jenna and Sam? But you'll notice that the first article on your report was not actually written by any of us, but it was an article talking about how great Martine Sanchez has received at the STEM Like Me event at Tijuana High School. So when we talk about community engagement later on in our results from GCACH, I think you'll find that this year there will be a lot more community engagement from a variety of Greater Columbia staff and partners to spread the word about our program. So just hats off to Martine. And yesterday he and Jenna also spoke in front of Leadership Tri-Cities. They had a full hour to talk about practice transformation. So I'll let you guys divide and conquer your reports.
So since I'm on the first, I'll go first. So this section was, the past month we've written about just kind of, what we're doing with the practice transformation. But this time we decided to focus on different sites that we're working with, on just kind of how the whole process is going for them. So for me, I wanted to highlight Columbia County Health Systems. They have been really engaged in this practice transformation work. And through all the meetings, Shane, their CEO, Shane McGuire, he has been really instrumental of putting a team together to do practice transformation and quality improvement. And he's been in contact. They have questions, they call right away, they email. And through this process, they have been able to identify some areas where they are planning on investing their money that they're receiving, their population health funds. They're upgrading their EHRs, electronic health records. They're purchasing templates to able to do patient rostering and within their agencies. So for me, I wanted to highlight them, being that they're serving rural communities in Columbia County. So that's what I wanted to highlight for them.
Yeah. And I chose to highlight Pullman Regional Hospital. They're doing a really good job of championing the practice transformation work internally. So they have Deb Watson, who's their clinical project manager, and she convenes all the meetings. She leads out on the meetings. I sit in on all the meetings in case they have questions, but she's really the champion. She had a meeting, so we have two. We have like a small internal group and then a large one. And in the small internal group, instead of her giving information, she chose people within the organization to delegate how we were doing on each milestone. So I thought that was a great example of them taking ownership. And in that meeting, Scott Adams, the last sentence in the paragraph, he said, "I think it's important to realize that the work we are doing is not simply to receive some money from Greater Columbia. The efforts we are making are laying a foundation we hope to build on as we pursue the next era of excellence in healthcare in our community." And so that quote was no prompting. He just said it on his own. And I thought that was excellent, because it's really showing that you can either look at this as filling out a workbook and getting some money, or transforming how you actually do care. So it was good.
And Lauren has a piece at the end, under our discussion items. So I think Becky and Rachel, you're up for your update. It's the Lynn Tracker.
All right, Amy.
Okay, so Okay, so here's a land tracker, looks a little different. They're one in blue or purple. Those are the new deliverables for 2019. As you can see, right now, the top, the top section there, that's the deliverables that are due, April 31st, no, April 30th. There's one there that's due this month, at the end of this month, identify to submit all the social determinants of health priorities. The only one that's not hasn't completed that yet is Whitman, but they're going to have them ready by the next time they meet, which is the 27th. And you see the dates there. Everyone else knows that deliverables, the leadership meeting participation. Everyone attended the regular leadership meeting. The rest haven't occurred yet, are not due yet. You see at the bottom there that the community health fund deliverables. Kittitas, Yakima, and Southeast Washington have completed the process to get for the GCACH to get their funding, and they have received their funding already. $740,000 and $742 have been dispersed already from GCACH. This month, we're also going to have Walla Walla, I believe, and Benjamin Franklin. The contract with Benjamin Franklin is pretty much complete. We're just waiting for them to a little deeper because they've identified the three major priorities: housing, mental health, and public security. They just want to get a little bit more detail as far as what housing and the same thing to mental health. So that process is pretty much complete. That's it, I think.
And we have the practice transformation tracker. So this is just the one that shows the overview of all the organizations. We have one that also breaks it down by site. So you can see that we have 23 organizations, so 46 sites. And you can, when you see that, when you're able to see that the dates do vary between some sites get their stuff turned in faster than other ones, but overall we're on track. Like we mentioned in the Leadership Council and Learning Collaborative, the due date for the first quarter of the workbook is April 15th. And so we're trying to be proactive, me and Martine, to not get a lot of emails April 14th. So we'll see how that goes. So yeah, we're chugging right along. So.
And we got Estria's contract today, and Memorial Physicians said that we should have it this week. So check it along.
We're still missing Estria.
Yeah.
Yakima.
CBHA tournament.
Yep. How long before they're on board, do you know?
Street Regional? I don't actually have a good answer to that. Working through some things.
Okay.
No.
Not.
So just for funding presentation?
Yeah.
Oh, I have my report.
Oh, sorry.
Okay, the total report is all kind of ties into all of my presentations today. But the funding that's in the actual board report is up to date. So tomorrow there's another just over $800,000 going out of the portal. So these numbers in the report are accurate to tomorrow. So we've got $3.8 million we've already sent out this year. Pretty exciting.
I'm sorry, what you just said, this is inclusive of tomorrow?
Of tomorrow, yes, it is inclusive of tomorrow. The financial reports are not. So then the other thing that I talked about in this report, Ruben just touched on was the loan contracts and the status of those. Those are all coming along, and the CPA agreements are coming along, and we're doing good. We're making a lot of progress. So, the finance committee meeting this week, we talked a little bit about the district funding, which isn't something that we normally talk about at the finance committee meeting or at the board level, but I was asked to put together a presentation to kind of talk about what district funding is. And I think a lot of you know, something this will be repetitive, but for those of you that don't, hopefully you'll learn something fun. So the presentation Rachel and I put together, the first 4 slides we took right off the Healthcare Authority website. I don't know if you guys have ever gone on that website, but if you go on there and you put ACH in the search bar, you get so much information about this whole Medicaid transformation project. And it, I always learn something when we go on that website. I'm sure Rachel learned a lot too. So we were putting this presentation together. So, and then the last 5 slides are spreadsheets that we keep in the finance department that kind of go over the district spending and how we track it. So let's get to it.
We're trying. It's tricking us.
Going pretty slow.
Thinking.
Okay, fine. Keep talking. So the first slide talks about the Medicaid transformation and how and
so Becky, maybe we could just we could come back after we get this. It's trying to load. I think it's trying to find our PowerPoint presentation, but everybody has the financials. So if you want to start with that, and then we can circle back, would that be okay? Thank you for being flexible.
So the financials, again, I kind of, the finance committee meeting, we talked about this a little bit, and actually, Les asked me some questions before the meeting about the financials, that they do look a little bit different than what you guys are used to seeing. So the budget versus actual sheet is the one that I'm going to go over for the board, but they look a little bit different because I think Rachel and I are kind of working together to streamline things and make them, I think they're a little bit easier to read. They look a little cleaner. And so on the budget versus actual, a new thing that we did this month is that we put some funding into what we're calling restricted funds. And so Carol was talking about the Yakima Lynn. We have been able to secure the $30,000 for that contract when it does go into place. We've got it's covered, and we didn't have to come back to the board to rebudget anything. So that's exciting, and that's going to be, so next month you'll see the first box with the revenue and the restricted funds. You'll see that money in there. And then the next box in our investments is our Numerica money account, and we've earned $20,000 year to date on that money. And that was something that Les and I were talking about before the board meeting, is that previously we were pulling down, and we talked about this finance committee too, we were pulling down money into our checking account more than what we might need for that month. And so we are not doing that anymore. We're trying to leave as much in the money market as we can to earn more money. So that's another reason why the financials look a little bit different. So it looks like we have less money than normal in our checking account, but that's because we're trying to keep more money in the money market account than we were before.
You also, Becky, when we spoke, and I don't mean to interrupt, but my recollection was you referenced there's a certain number of times you can access funds out without penalty or whatnot. So that had to do with some of that strategy as to how you're going to pull that money down.
Right.
We had a little bit of detail in our conversation about how to do that effectively. So we want to be real careful with how we draw those funds.
Right.
So we're good students.
Yes, and something on our plate for the finance committee this year is to figure out what we're going to do with that money earned. Last year, the way that it was reallocated back into the budget, and we're not going to do that this year. That'll be something that we'll discuss and bring to you guys when we have time. In the expenditures box, you see our payroll, contract services, professional services, office and technology, travels and meetings, staff training. I want to talk a little bit about the staff training. So something new in the budget this year is that we put each of the staff get $3,500 for professional development. And so we've already spent $8,000 of that this year, and I think that's pretty exciting. Martine and Jenna are going to the IHI conference. Rachel and I have been to a couple of conferences. We went to the Women in Business conference through the local chamber. So I think it's good. We're all going to the local conference, well, most of us.
Sweet.
So it's good. I'm really happy.
No
that we
conflict.
did that.
Really, no conflict.
So our total expenditures for the month were $178,637, which is right in line with what we normally do, I think. Are you having anything? Oh, yes. Not so much.
No, we had a very, very good meeting. I'm grateful for the added help. Jorge, thank you so much for being on that committee. It's very helpful to have you there. Becky did give she gave the high level of the hour presentation that we did, which is fun. Yeah, that's good. And that is good. That's, but the important part is, I believe that this document here speaks to statement of activity, right? And it has the, little gray boxes. As you need to, or should you need to dig in a little bit, Becky's done a beautiful job of presenting the specifics as to each of these entries, and it makes it very, very easy to go through them. We ask a couple questions, we clean them up a little bit. So by the time we get them to you all here at the board, they have been fully vetted. So I would move that we approve these minutes, or I'm sorry, approve these financial statements. Thank you very much for your help.
Thank you very much. Second from Ronnie. Is there any further discussion, questions, or comments about the financials? Hearing none, all in favor?
Aye.
Aye.
Any opposed? Any discussion? Okay, thank you, Becky. Thank you, Brian.
Thank you.
Sorry, Becky. Yeah, should be working now. Sorry.
If I mess up, I'm
Blaming on me.
IT support.
Okay, so the delivery system reform incentive payment. This is the money that we pay out to our partnering providers through the financial executive portal. And it is money that is earned. Oh, we can go to the next slide. So this is money that is funding that is earned through the Medicaid transformation from the Healthcare Authority. And we earn it based on our performances that we meet and our reporting that we submit to the Healthcare Authority. And it is all overseen by a group of,
Are you talking about PCG or?
yeah. No, the auditor.
The independent evaluator.
Yes, thank you.
Financial executor.
So on this slide, this shows the district money coming in and the delivery system reform interventions. It talks about the DDP arrangements and rewarding for our progress. I think that I feel like something that this slide is missing is in the middle. I think the ACHs and the NCOs should have been there in the middle of that little diagram. All those things circle around us, and we all work together to bring this money for the district. So this slide goes a little deeper into the actual funding pool, which is what the Healthcare Authority calls these. So you see on here the value-based payment incentives, the integration incentives, design fund incentives, which is what we normally report to you guys and what you normally see as our operating expenses. And then there is also money for incentives for the ACHs and for the NCOs to earn extra money that's above and beyond what we're asked to do for our reporting. And Carol, please jump in here if I leave anything out.
You want questions along the way?
Sure.
Can you easily explain the difference between the VBP incentives and the project incentives?
Yes. So the project incentives are what you earn toward every project that we have submitted to the Healthcare Authority. So we actually get money through these project areas, and we have bidirectional integration, opioid as the required projects, and then we've chosen transitional care and chronic disease management is our other two projects. So when you look at the income, it actually is delivered into those 4 project areas.
And there's a slide about that.
Yeah. And the design funds, they're done now. We went through our certification processes and we earned those design funds, and those are maxed out at 54. All of the ACHs earn design funds based on their Medicaid population and their reporting requirements. And then the VBP incentives, we have not tapped into those yet. Those start in year 3 this year. And there are certain performance measures around value-based payment, because really that's one of the goals of this whole program, is to get as many providers as possible into VBP arrangements. And so there are performance milestones that we have to achieve. One of them is the number of providers that get into VBP contracts, the methodology that we are using to try to get our providers into VBP contracts, and I think that there's like 4 or 5 milestones. And that funding is separate from all of these, but it's the same across all the ACHs. So I think the maximum amount for all the ACHs to earn is around 6.2 million, and we won't see any of those until later this year if we earn any VBP incentives.
So, as providers, I know in primary care, I don't know if the hospitals probably get this too, we get these annual surveys about our contracts. And is that what's being measured for this?
Part of it, yes, part of it is. But part of it was like, one of the questions was, how did you get the word out to take the survey to your providers? Did you incent them? Did you pay them to take that survey? We did not pay providers to take the survey this year, but I can tell you that we had a higher rate of return for those surveys this year than we did last year. So according to the Healthcare Authority, those are the kinds of measures and performance that they look at, is how well is the ACH doing in getting its providers to fill out these surveys so that they have that kind of information.
So one more question, just so I can track it. So the VBP incentives are paid to the ACH, and so then can those be translated into project incentive dollars? Is that your idea?
We can use them however we want.
Yep. So the next slide kind of drill down a little bit further into those, but.
And then the integration incentives, that was the money that we paid out for the IMC.
Yep. So all this money gets put into the portal, what we've earned of this $1.12 billion that they've, for all the ACHs. And so all of our money gets put into the portal. You'll see later, we've got about $24 million in the portal. And that's all for these projects in our contract. Next. There we go. Okay. So this dials down a little bit more, so you can see the first box is the financial executive portal, so that's where it starts, and then it funnels down into the different the pools of money, the design funds, the project areas, and then the PVP pool. And then it shows how that money again funnels down through MCOs, and then it goes into our project areas, which the next slide tells you what those areas are. There's also the use categories that are in the portal. And that's how we, in our budget, you've seen those use categories, and that's where we pay the money to. So we have all the money that's in the project areas, and then we pay into the use categories that are in the portal. And those are all on the other side coming up.
Can you tell us what MCO challenge means?
Yeah, I was going to ask Jorge, but I think it's your pool.
Well, supposedly, and we haven't talked about the challenge pool in a long time, and Kat, correct me if I'm wrong, it's been like 2 years. Supposedly, this is money that when you roll, it's probably better explained with the other slide, with the slide before.
Mm-hmm.
So the incentives that come from savings on VBPs could have 2 potential, first of all, there were this money called the VBP incentives, then we took a chunk to incentivize regions to move to IMC. So from the other one, it could take two different routes, basically. So one reinvestment pool will go here for the communities to work through the ACHs, and the second one would be part of the incentives for MCOs to achieve their quality goals, which is connected loosely. I don't even understand how it is yet, and I don't think the Healthcare Authority has gone to the 1%, 1.5% withhold that we are held from the healthcare authority. So it's just more money to incentivize MCOs to meet our HEDIS metrics and our quality metrics as the ACHs and the providers contracted are. And keep me honest here, Kat, because I haven't heard about the challenge pool in probably a year.
So we actually have an exhibit now in our contract, so many of you may be aware
Yeah.
of the other value-based payment exhibit that has an always upwardly mobile number of withhold dollars for 1% last year, 1.5%, 2% in the next year. And then there's a second exhibit that lays out the expectations of that challenge pool. It's tied to performance, it's tied to percentage of payment, so along the framework of the APM, as well as tied to a couple of other areas. So there's also pay for reporting and pay for performance. It's probably one of the most confusing contractual exhibits I've ever had to decipher.
Is the term actually in your contract?
It's in the managed care contract.
Yeah.
From the state to you?
From the
Yes,
yeah.
in all of them.
Yeah. But it is tied to what we are expected to perform on related to value-based payments, which many people will see in their contracts with managed care organizations when we think about the metrics that we're including in value-based payment arrangements and the advanced, if we're engaging with you in an advanced arrangement that helps support the performance on that contractual element.
And it is potentially more confusing for the provider because the provider will be approached from two different sides with two different amounts and two different ways to measure, because the way that contract asks us to measure it uses the same metrics, but the formula of what they want to measure or the formula you guys decide to have to measure the incentives for your providers can be completely different.
When you say the formula is different, are you saying that the underlying numerator logic is different?
It could be the denominator too, because it is not clear.
That's very confusing.
Well, for the provider, it will be more confusing because we have our own document to go by, and I'm expecting that to get better because I didn't understand it either. And you guys will create your own rules. So for a provider that is agnostic to this sort of, and that only has a 2-people QI department, they will have to deal with 2 different rule books.
So originally, I thought that all the measures that were in your contract with the state came out of were tied to the common.
No, the measurements are common, but the formula of how you rate your achievement could be different because of the amounts of money. No, it's not that we're going to have 2 different sets of measures. Thanks, but we don't.
Sorry, I was confused.
No. I'm glad you brought it up because it's not about changing the metrics. It's about changing the formulation. That's why I use the word formula to describe, because that could be different.
And if you want more information about that, there's a 138-page document on the federal government guide that I read, and it goes into great detail. Wow.
Yeah, that's available to, I think we tried to pass that out before.
It's on the healthcare authority website.
So let me ask you something. With all that confusion about what that is and how you access it, have you been able to access it?
To access the pool?
Yeah.
No, we haven't yet.
It hasn't gone into effect yet.
No.
When does
This is
it
the
go into
first year
effect?
that it will be measured. So we
Okay.
measure the year post, so technically, last year, 2018, was performance year 2 for the value-based payment exhibit for our contract, and so we report on that in August of the year afterwards. So right now, we're in performance year 3, everyone. And so we would report on this year, next year, so. Yeah.
But what you get is based on what you do this year. Last year was the baseline of some sort, right?
The year before was the
Year
base,
before,
yeah,
okay.
so
17.
actually, yeah, 2016 was
17 is the base
2017 was our first performance year. So it is all based on what we did the year before.
And when will you gain access to that?
2020.
So, correct. Well, by the end of this year, we will receive our withhold payment that was held last year. We will receive, if we perform to the expectations of the contract, we will receive the withhold from 2018 at the end of 2019.
And that is not touching yet the challenge pool.
So if I was the provider, is that happening the same thing, that you withhold and it doesn't make the metrics, and I get that at the end of the year?
Sorry, I was
So if
joking
I was
here.
a provider, is it happen the same way, like for you, where I've got some of my Medicaid money is withheld until the end of the year if I make my, what are those things they're called?
Well, let's say just that depends on your value-based agreements with every MCO.
Okay.
Different MCOs can take different routes on how they incentivize your achievement of your metrics.
So if I have three NCOs,
Yeah.
I have three things I'm working with besides the ACH, besides, I'm sorry, it just seems like it's getting more complicated.
Yeah, I guess my other question there is, do the incentives, does that apply to the behavioral health providers now too, under IMC?
Not yet, and if you remember one of the presentations this morning, I want to say was Brian's, speaking of right now, he still operates in fee-for-service mode because we have not fully implemented the philosophy that is going to become the way we do value-based contracting for behavioral health.
But a lot of, well, I guess maybe I'm not answering it the way I mean. Because a lot of the metrics happen, thinking about Brian's presentation, in the integrated managed care world, if we're doing both, I guess the question is does this apply to both? Will these incentives apply?
I believe they should apply to both. I don't think, and Kat, correct me again if I'm wrong, we have not seen yet a first document from the healthcare authority that says this is how value-based contracting for behavioral health is going to work.
I think there's an interesting way in which, you can measure value-based payment and the percentage of payment with respect to the contract. And what it's measured by is the percentage of payment. So if it's a total cost of care arrangement that actually includes that entire cost of care, that is recognizing the cost of potentially the hospital, the behavioral health, the different, within that space, so that could count. So when we're thinking about percentage of payments, if we have 67% or 72% or 80% of our payments within value-based payment arrangements, that may be with respect to sort of where the arrangement is held and sits. There may be arrangements underneath those arrangements that tie into, because you have dominant arrangements, and that's the way in which the healthcare authority measures value-based payment. And that's how CMS measures it too. They measure on the case of the dominant payment arrangement. So if you have a dominant arrangement that sort of supersedes then that arrangement, so then a behavioral health provider may have a value-based payment arrangement or may have a fee-for-service arrangement, but technically because of the total cost that sort of is underneath a total cost of care arrangement, it may not count. So it's a real, it is, right now we're sort of entering a space where I think we're all trying to go towards that same goal, but when we're considering the way in which the healthcare authority is messaging that everyone should be within a value-based payment arrangement, it gets us to that shared goal, but it may not necessarily impact the way in which it's being measured at the healthcare authority level. If that makes sense.
Okay, that was clear.
Okay.
Everybody still on board?
Okay, so.
Right.
It answered my question. The end of it.
Okay, let me just check in. Folks on the phone still okay?
Yeah. Should we go to the next one? Okay, so this one talks about what Carol was just talking about, our project areas.
They were there. I don't know where they went.
Okay, so there was the boxes around the four that we've chosen, that Carol identified them, and the bidirectional, transitional care, opioid, and then the care coordination.
Chronic disease.
Chronic disease, sorry. Chronic disease. So that's all the slide is showing, it's just the project areas that we chose. And so this is in the dashboard in the financial executive portal. You see all our 4 project areas and the dollars that have been assigned to it. And then you also see the use categories that I talked about, and that's what we actually pay to, which you'll see that. So this has the category that says district project incentive fund. So that is what the portal calls use categories. And so these are the use categories that we have budgeted to and we are paying to for this year. And then there's 3 that aren't listed on there because we're not using them right now. It's provider performance and quality incentive, our reserve contingency fund, and then the shared domain 1 funding. So, but the rest of them, those are all the use categories that we're paying to and budgeting to. So this, at the finance committee, was asked that we also report on the budget versus the actuals in the district funding as well as the design funding. So we'll start bringing this spreadsheet as part of our financial reporting for next month.
Shared domain 1.
That's a fun question too.
I'm sorry.
So that is the intergovernmental transfer.
Well,
IGT funding.
But in terms of how it's used.
Can you go back to the last slide?
The way that it's used, you don't have a.
So, in the capacity building, there are really 3 things under that: the VBP, the workforce, and the systems for population health management. And we have actually set aside funding in our own district budget for these 3 things. And so, and you'll find also in our district budget that we have set aside certain provider milestones that fit under these. So systems for population health management, if you're spending funding to help improve your EHR or buy clinical decision support tools or something like that, that's a milestone, and that funding then would be allocated to that. We've set aside money for workforce and capacity building, and again, some incentive payments for our providers. So it all flows through our district budget, but we haven't spent some of those use categories yet, but we will throughout the year.
But that money would come from that first full domain 1.
Yes.
So yesterday we had the DMHI meeting, the IT meeting where Wes briefed us on all the projects that we're doing in IT for GCACH. The cost of those projects would be paid off domain 1.
Yes.
So that's what's important. And it doesn't show here because it's 0 right now. Right? But it will be money.
Did you have a question, Ryan?
Kind of. I know, you look like you're cringing. So I'm trying to wrap my head around this. Not started school in the shed, but I'm trying. So the funding in the district stays in the district.
Yes.
Correct.
It stays in the portal.
It stays there, and so as you meet these certain criteria, it funnels down to that specific that you've met, or is it, how do you access those funds from the district?
So every 2 weeks, we can make payments to our providers out of the portal. So every 2 weeks, payments can be made.
Right.
And however we can use them. So at the beginning of the year, we pulled down payments out of the administration fund, you can see, and the project management fund, and we pulled that down and put it into our GCACH account to pay for our payroll.
Okay, so the district specifically for GCACH is a pool of money that's sitting there specifically allocated to us.
Yes.
Okay.
Every ACH has their
own
of that, for the money we show on that.
Okay, so if we don't utilize those monies by the end of the fiscal year, then that money is no longer available.
It
rolls over?
Yeah. It's for the whole, yeah.
Okay, I'm just checking because I gotta wrap my head around stuff and I'm not really certain.
No, you're totally fine. So if you can see our budget for this year, we have $24 million allocated, and we actually had close to that in from last year because we didn't spend a lot of money from last year.
Right.
So, but this
report is
year.
2018, Becky.
Yeah. Oh, this is
2018
2018. Oh, the next one's 2019, I apologize. So you can see we didn't spend a lot of the money in 2018, this is 2019.
But that rolls over to the next. So
Yes, it
the first funding that we got, that one wouldn't have rolled over, is that correct? It was the,
The design.
Design funds, that
Are in
rolls,
our-
that rolls also. So that.
which
It's in
one?
our
was-
bank account.
It's in our bank account. The design funds are all in our money market account, and then we pull them and pay our bills.
It's also important to consider that it's sort of a stair step down from this point forward.
What's the earnings?
Wasn't there one that didn't roll over that you had to use?
Yeah, the SIM funding.
SIM funding, okay, so I'm getting all this
Yeah,
confused.
That was spent out.
And that's already been spent.
So we received basically the year with the highest amount of funding going forward, it steps down to like $5 million increments sort of, in a stair step down. So we've really received peak funding on an annual basis.
That's good.
Which is good because our foundational work relates to practice transformation with those funding expenditure.
Yeah. Perfect. Okay, now I got it.
Okay, moving on, Lauren. So this one, this is a slide that Rachel put together for Rhonda because she likes to see graphs. And so I thought it looks like one of the values didn't come through, but so Rachel created this as a graph to show the same thing on the last two slides that we just showed.
Which values, I think? It's
The one in the middle, the integration.
Yeah.
I don't know, it sounds,
We haven't, that's what was for
it came through on the
Appreciate
spreadsheet. And so there's our graph.
So your budgets and actual for project management and administration are, those accounts are paid out.
Yeah, we brought that
Yeah,
down.
Yeah, no,
We brought it down from district into our operations budget.
Okay.
Our tax out.
Okay. I mean, I understand why you do it, but I'm just making sure I read it right.
Yes, we're all gonna get paid for this. For sure.
Just really quick, can you give me an example of integration incentive?
Like the IMC funding that we paid out to each provider, that's what the integration incentive funds were used for.
Okay.
There's another, there will be another, set of money that will be coming, and that was the one that we will have to decide how we will distribute it again.
This is showing that nothing's been paid out for the integration incentive? Is that right?
For this year.
For this year, because we expended all of last year's $4 million. We're expecting the $6 million between May and June. One of the recommendations is to have this group determine how that fund will be allocated as opposed to the way that we allocated it the last time.
Mm-hmm.
And one of the recommendations then would be to use some of that money for perhaps incenting mental health, behavioral health trainings or positions in our organization.
Will we have the same amount this year as we had
We'll
last
have
year?
more.
We
We'll have
more.
6 instead of 4.
6.1 million.
Very
It's on this one, but it didn't flip there.
Yeah, you have it. That's the projection for
this
year. Yeah. Yep. So it'll go through the normal process. It'll go through the budget fund flow and then finance and then DU once we have some guidance on what we should spend that money on for this year and how it should flow. Yeah. Okay. Good questions, you guys. Thank you. So this is one of the contracts that we pay out of the district. These are our 23 practice transformation providers, the total amounts that they were awarded, and then in the paid column is what they've been paid today. And like I said earlier, this does not include March, so this is over $800,000 missing off of this. Plus, what we still have one more payment period this month also.
And how many providers are missing from that list?
That's everybody, 23 providers. That's
Sorry,
not,
that's just,
yeah, just for practice transformation. That doesn't include their clinics. So this is just the upper level who we contracted with, and then in each of the contracts it has their clinics, and they each have their own schedule.
40.
And then the next one is our spreadsheet for our third-party administrator agreement, which we also pay out of the district funding. And as you can see, we've already paid out to 3 of our providers, and then we still have a couple more to get contracted and get paid out to. So we're working with them. So they're coming. And that's it.
Great, that's very helpful.
Good.
Additional questions from the board?
I do want to commend you guys for the work. It's a great presentation. You know, where we were a few days ago and how confusing this is. This could be one of the best presentations from top to bottom on how this is rolling. And it's so good that I understood it.
Hold on to yourself.
All right, when you mean where you were here?
No, when we
days
talked about
in
the financial committee.
Oh, okay.
Yeah,
All right.
finance committee, there's so many things with letters.
Yes.
I don't know which one that is.
That is pretty good.
They're good.
Just within a few days.
It's
To
really-
sharpen it up.
It's really good. And as we were talking about it in the finance committee, started realizing pretty quickly that there's new members on the board. And, you know, some of us have been here for a couple of years and it takes, it took me a year to understand.
Mhm.
So before we go past, let me ask if our members on the phone have any questions or comments? Julie, are you still on? Is anybody on the phone?
I don't know.
Yeah, well, that's what I'm checking.
Julie's still there.
It looks like she's muted. Okay. Oh, you've got everybody muted. Is that what that says? Oh, no.
No.
It doesn't look like she's connected to any audio.
Okay. Okay, so we will assume that if you can't talk to us, you'll chat with us if you have something that you need to say or want to say. Okay. Okay, all right. Well, great presentation.
Yeah, that's
Thank
really
you so
good.
much.
Thank you.
So if there's no further comments about the district funding, then let's talk about the telework policy. Cheryl, do you
Well,
want to talk about that?
I'll just key it off, but I think February is a really good example of why it's important to have a telework policy, because around here, it would change from day to day, whether it was a 2-hour delay from the school district or a 3-hour delay, or if a school is canceled. And so we kind of decided that we need to have it written down so that everyone, all the employees understand what our telework policy from home is. We have a long-term agreement for teleworking, but we never had a short-term because we've never been faced with the kind of weather challenges that we had. And we have some employees that have children in the school districts. The different school districts have different policies. And so Becky worked around all of the things that we experienced and put it down into writing so that it's clear to all the employees when they, when they start with Greater Columbia ACH is what is your policy on teleworking? So Becky, you can just take us through what you wrote.
Oh, sure. Well, like Carol said, we didn't really have anything, and so we all just kind of worked through it together. I think we did a really good job of communicating. Carol would send out an email or a text to a group of us in the morning and say, hey, it looks like this school district and this school district are closed, or they're on 2-hour delay, and so drive safe. And then there was a couple days that our office was actually closed also. CAC closed because there was so much snow in the parking lot that nobody could park their cars, so they closed the whole building. So and we realized we really didn't have any process in place, and so we all communicated really well together, I think. But then once it was all over, we thought, well, maybe we should put it in writing just in case it happens again next year.
And we were really glad for OneDrive so that we could get documents from home that we could share. It made a huge difference.
Yeah, technology really helped all of us stay on track with our work for the time that we were all home working. So anyways, I put this together. I reached out to the other ACHs and I asked them to send me their entire employee handbook, which they were all gracious enough to do.
Really?
Yes.
Wow.
So Rachel and I are actually updating our entire employee handbook, which is
That's
exciting, based off of the information I received from them. And so I took a lot of this from all those different books and our experience from the time that we were all teleworking during the snow, and put this policy together. So it pretty much talks about what we just said, that we're trying. We will follow the guidance of our executive director, and then we also put in here that we would, if you do end up having to telework, that there is a form that we would fill out. And in our current handbook, it does say that if you are approved to telework, that you have to fill out details of what you did that day, what work you worked on. And so Rachel created a form, which, sorry, we didn't bring it to this party, but we do have a form that the employees would fill out, and according to this document, they have to fill it out on that day and give it to the supervisor by the end of the day, so that they know what they did for the day. So that's kind of what I put together, and have any suggestions or.
Just have a couple of questions. What percentage of the staff has the ability to telework?
All of us.
100%.
100%, yeah.
Just checking, you know.
Yeah, so one of the things that we did in the last couple months is we worked really hard with our IT provider and got OneDrive set up for all of us, and so we all have been using that to store our documents. So we all have a login to our OneDrive. We have a OneDrive that is accessible to all the GCACH employees, and then we have ones that are restricted, like the finance one is restricted. And everybody, some people have rewrites to parts of it. So that's what we.
Then my next is just more like walk me through this policy based on a scenario. So say a storm is coming and we need to send staff home 2 hours early because the snow's coming, safety's closing in the building, and you guys all have to get out. What happens to employees' time? 'Cause that's, for a lot of people, maybe not enough time to get home and actually begin teleworking. What then?
Right, so the handbook covers that kind of scenario also, just based on, of course, salary employees. So we do have 2 employees that are hourly, so that would be, the salary employees would just flex their time, which is something that we've been talking about. If it's just an hour or 2, then that's already in our policy. So that is another scenario that actually did happen. It started snowing pretty bad, and there was a couple inches in the parking lot. So yes, and things are going to come up and things are going to happen that we didn't cover. Things, to be honest with you. But everything that's in here is all at the discretion of the executive director. Whatever Carol says is what we do.
So then I guess I just want to make sure that this allows for the discretion, if we truly care about our employees and our people's safety, that they could actually be paid for that time, even though it's not. So for example, at my organization, in the event that we have a corporate closing of a site due to inclement weather like this or any other like major power outages or et cetera, whatever, if the determination is made that we are closing that site early, employees are still paid, and that's just kind of paid under a different pay category than PTO or any flex time or any of those things. And it's written off against, you know, time loss for an insurance claim if we end up filling one out, or it's just written off as a loss.
Right.
Versus making employees in those situations always have time to have the opportunity to request a leave early and take PTO, but if they're there working and willing to stay and work, but we're making the decision to close, we don't punish them by making them flex their time or use PTO.
Right, and we wouldn't either.
Okay, so I just want to make sure the policy allows for that.
Yeah, so if I send everybody home 2 hours early, I don't take 2 hours away from them.
I want to make sure, you know, you treat yourself well.
I was waiting for you.
I know. Perhaps that should be put into this so that it's clear. To me, it's like if I have to close down because of the inclement weather and it's due to snow or other issues, and I'm closing my business, I'm paying my people. And when I did have my businesses and I lived in Montana, there was snow. There was lots of snow, and I paid my people through those days. You know, and snowplows only get through a certain amount of time. I've paid up to 3 days of lost time because of the weather. And I think that it set with my people better because they felt like they were being taken care of. And that's what I think we should be doing for our people that are working so hard and trying to get these things done on time. But I also know that there's always emergency things that come up.
Right. And I trust Carol's judgment, and I just want to make sure the policy is reflective of that.
We're on salary, so, and we all have laptops.
But there's a couple people that are on hourly, so let's pay attention to that too.
So there is a sentence in here about that, maybe we could build it out a little bit more.
Please. Okay, we have a couple of other comments, Carrie,
Um,
and then Madeline.
So is this available, or the form that they have to fill out to say what they worked on, available electronically?
Yeah, it's on our OneDrive. Oh, yeah, it's got it.
Oh, okay, okay.
Print it from the board.
Yeah. Okay, because it says it has to be turned in by the end of the day they work.
Yeah.
And if they're not here, then they just email it. Okay,
It can
gotcha.
be emailed to them.
Madeline.
And actually for us, we have to record time work. And so we do have a pretty generous annual leave for individuals. So individuals can request annual leave when there's a delay start. We want everyone to arrive safely,
Mhm.
and they're not going to get penalized. But actually, with our grant-funded programs, we have to go by hours actually worked. And so we'll allow the flexibility for someone to take a half-hour lunch and work, 8.5 hours, or work over the next, or sometime within that pay period, to make sure that we're accommodating that. And it's worked well for us over the years, and actually this year as well.
My only question is, do we want to have our legal counsel look at this?
We could.
There's been a lot of changes around PTO and leave, and does it benefit one group more than another?
If we're gonna do this, should we do the whole employee handbook at once?
Depends on how urgent you feel this time is.
Well, I think that the danger goes. We may have floods. Yeah, the floods,
Right. No, seriously, it is up in our area.
Yeah, and there have been, since the last time we updated the personnel policy, there have been changes to PTO.
family
and
leave,
leave, so it is timely to have that, have some updates made. So if you're not feeling urgent about this, then it might be a good time to just put this in front of them.
And then bring it back.
And
Yeah,
then bring it
because I
back.
think you had contacted 501 Commons, right, that has staff that can help us review that.
Yeah, they are. I'm very underutilized.
So we'll bring it back with the other policies if we find anything that needs to be changed.
And just one other area there that, to also take a look at exempt versus non-exempt. That's another area that scrutinized kind of heavily. So,
Probably the smallest of the suggestions, almost a style suggestion, when you read and say that it's going to be loosely based on local school closures, could we say something more like the executive director will take into consideration, just, formal documents, you don't want to do anything loosely, although we all understand.
Right.
But just,
And that might be one of the pieces that come out, because people who don't have children may feel that they are unfairly.
yeah, we don't, exactly, I don't go by what the schools say, I don't have children.
Right.
Taking in consideration things like.
That's a really good suggestion.
No, I can definitely think that wording, and just the logic behind that is, all of our staff, right, don't have kids, right? And someone down there has an all-wheel vehicle with studs on, so he came to the office,
Mhm.
and the rest of us were all.
He's just a champion of snow and ice.
But we've got 5 different school districts.
Yeah.
So we're all, that's why.
With the executive director's criteria.
You're right.
right. And not too heavily relied upon, because you don't want her to say it's safe to have preparedness.
And then somebody gets injured.
Right. So there's a lot of, areas to consider.
Okay, so good discussion. So we'll see that back as part of the personnel policies overall.
That's a good suggestion.
Okay, so cross ACH collaboration SBAR. Sounds like a mouthful.
Situation, background, analysis, and recommendation. As the board is aware, the ACHs have been meeting regularly now for over a year on a monthly basis to find alignment on areas of common concern. And last year, we were working with Deanna Davis from Applied Insight. And towards the end of the year, we realized that some of these issues are thorny enough that we need more subject matter expertise than just facilitation. No slight to Patrick and what he does, or any facilitator, but sometimes you need somebody with actual subject matter expertise to help you get over the humps of decision making. So in January, the ACHs came together, and we, I guess it was February, because I was home at work, and we put together a request for proposals to cover areas specifically related to our HIT, HIE strategies, because across the state we're all approaching HIE and HIT differently. We felt like we owed it to our providers and to the organizations that we work with to have as much alignment as we could when it came to HIE and HIT. We also needed some direction on how to move forward information sharing, bidirectionally. I know Susan McLaughlin of Healthier Here is very interested in coming up with a standardized care plan. We're all very interested too in how can we align a community resource directory of sorts, because we're all relying on different kind of community directories. So we've kind of started thinking about that, and then have this consultant put together an actual implementation plan based on how the 9 of us can agree, and actually reach an agreement for all of us to come together under a single contract has taken us this long, to come to that point. So we put out an RFP. We had 4 people, 4 organizations bid on the contract. We interviewed them last month. Each one of them was provided about 30 minutes of our time so we could ask them specific questions about their request for their proposal. And we unanimously chose Artemis Consulting. Artemis Consulting is really a collection of contracted people. So they have come together under a single contract, which includes Kathy Kaufman, who we worked with through Health Management Associates. Bruce Goldberg is part of that team. A new person, Diana, I can't remember her last name.
Bianco.
Yes.
Bianco.
And there's one more person. Oh, Rim is from California, and he's our IT expert. They gave an excellent presentation, and we decided to hire them. And then the next big decision point was, well, how are we going to pay for this? So the RFP was not to exceed $170,000. So we divided it into the large, medium, and small ACHs. And so our share would be $19,200 for the year, so that we can share in the cost somewhat equitably. This funding would be taken out of our operations budget, of which we've allocated around $200,000 for contracted services. And so we have the capacity in our contracting budget to be able to pay for this service. So it's our recommendation that the board approve this contract with Artemis, and this contract will be administered by Better Health Together. They were the ones that put together the RFP, and then they will administer the contract.
Is the goal that out of this would be shared platforms by online of the ACH?
The goal would be to at least understand all of the different needs that we have, and if we can come to some agreement on shared platforms, that would be wonderful. There might
not necessarily.
Yeah, we might reach a point where there is a no or no-go on a decision, but at least then we can say, these 5 ACHs want to go this direction, these 4 ACHs want to go a different direction, but at least we all understand what directions we're going. So it might not be unanimous, but at least now we have a methodology of talking to the healthcare authority with a single voice.
Right.
And as soon as the healthcare authority found out that we had approved this contract, we had a meeting on Monday to go over HIE, HIT, because now they have an ability to get to us under a single name.
So you have a unanimous recommendation from all the ACHs with this company, correct?
Yes, and so we are the last. I said I would have to bring this to the board for their approval, so we are the last ACH to approve or disapprove of the contract, although I should say all the other ACHs have approved their contract and agreement. No pressure.
I like it.
There's some things that really make sense here. Pre-manage is one of them, integration of pre-manage into primary care and behavioral health, integration of the prescription monitoring database. I think those are things that all of the ACHs agree are important in terms of integration and implementation. There are things that we're doing that will be and continue to be unique, such as the PSI reporting platform. There are 3 other ACHs that are using that. The others probably will never use that. So for those areas that make sense, this is a good idea.
Well, I'd like to make a motion, if you're entertaining them, that we allow GCACH to participate in the Washington State ACH Collaborative with Better Health Together as the contract administrator and Artemis Consulting as the contracted.
You better slow down.
I'm reading it from the recommendation.
Okay.
There you go.
She comes from the recommendation.
Yes.
Okay, is there a second? A second by Ronnie. Is there any other discussion or questions, Jorge?
A couple of comments. We actually met today in our taco caucus with Kat and Caitlin and Marisa, and we discussed this. We really support the idea of doing this because we, the MCOs, see how good it could be to have a single-minded approach to many of the things that would be working with us. So we're generally very supportive of it. When you read that, we also have to say that many of the boards that we belong to, all of them, in every board, we have a representative. There hasn't been this proposal presented as it is right now. So you're the first one who really puts forward a proposal to approve the funding for this. So good on you, and perhaps we need to ask some more questions in some other communities. But this is good. Now, when you look at the writing of this, there's still this very first draft of this, so the language is vague, and we would like to know more on what we mean by a number of things. Like what we mean by working on the sustainability plan. What we mean by, and this touches our hearts, is negotiating with the MCOs. What does that mean? Are we going to have a consultant talking rates with each MCO on the Pathways Hub? Or so it could be a good idea to perfection the contract, to finish the work with this consultant, and to create this is what the contract is going to look like, and maybe to bring it back to the board so we can ask some more questions.
Okay, we'd be happy to do that. I know you don't like it so vague, Jorge, but I actually don't mind that it's so vague because it does allow for us to move some items forward where there is consensus and, do our own things where there necessarily isn't. So I'm actually not quite as concerned about the vagueness.
No, and I think at this point it's perfectly fine that it is vague because it's just the idea, let's work with the consultant. And now when you hire a consultant, you do want to be a little more specific on what the limits of it could be. So it will be probably somewhere in between what it is today and
you are right about collaborative contracting.
Yeah.
You gotta be careful of that.
Mm-hmm.
You gotta be careful of that anyway. Yeah. So I appreciate your point. Good.
Additional comments or questions? Having none, all in favor?
Aye.
Aye.
Anyone opposed? Anyone abstaining?
So do we have agreement that we'll bring it to the board again for a review when you have a document? Okay.
Great. Okay, April board retreat agenda.
So, Chris Kelleher, who is from OHSU, who is our other contracted vendor, and we work very closely with Dan Bizzini, who is one of his staff on fund flow modeling, but Chris Keller has done facilitation with our practice transformation work group. Chris and team just did a retreat with North Central on sustainability planning. And so we really relied on the formula that North Central came up with to drive the agenda for the board retreat. But we wanted to bring it to the board in case you guys had some other ideas or wanted to go in somewhat of a different direction for our retreat. And I would say that one of the first questions that came to mind is, we tried to find a place different from this for a retreat because the retreat's supposed to be a little bit more relaxed, but it was difficult. And so we're asking your permission to go ahead and have this retreat, which is really in place of the meeting next month, to have a single item. We're asking your permission, number one, to have it here as opposed to going off-site and trying to find another place. We just thought we wanted to kind of press the simple or the easy button on this one. So if that's okay with you guys, we'll be here next month, right? We did try some other locations, but not as many advantages in terms of technology or space. So, and
more money probably.
And it would have been traveling somewhere else. And the second was attendance. You know, do you want this to be open to everyone, or are you looking more specifically at just having the board and staff? Did you have a preference on that? So those are the first two questions.
Space will be an issue here, to open it up to many more than
Okay. Is that okay with everybody, primarily board? Okay. All right. So let's go to the PowerPoint presentation, Lauren. So what Chris did for North Central is it's very kind of some pretty basic information of what are your long-term goals, and then laying out 4 different options to discuss. So it's not a very extensive agenda, but it really gets at the heart of, you know, what is the board's vision? What changes do we want to see within our region for, you know, between now and 2040, and then the 4 different options. So let's just flip through the slides. So basically a discussion on the board's vision for GCACH after the transformation project. And then what changes do we want to see within our provider organization, social determinants of health and health equity as a whole. And then this is just a way to capture some of those desired changes in all 3 of those domains. And then, is the ACH critical? Are we really needed in reaching those goals? And ask the questions then, if we are, then what are the 4 options that you have? And so here were the 4 options that North Central came up with, and then we modified them very slightly. So the ACH exists roughly the same, with some slightly different resources and capacity. We'll go to the next one. And then there's a little bit more detail. Then the resources and capabilities are reconfigured. Were replaced by a successor organization. Like for example, you can go back more in like the local health improvement networks, or maybe there's another outside organization that you would like to see. And then the final option then really is we're just sunset and we go away. So that's kind of the gist of what we would be talking about next month. This would be preceded, though, with a funds flow model that Dan Vizzini has done for us. We reviewed it last week with some assumptions of how we've spent the money to date and carrying that forward, so that you can see, before you talk about these 4 options, what does the funds flow model tell us? And then I think that will help inform some of your decision making. So it would basically be a review of the funds flow modeling from Dan Vizzini. He'll be online to answer questions and take us through the different models. And then Chris would lead us through kind of the long-term vision for Greater Columbia ACH.
Sounds right to me.
Sounds like a big question?
Those are the things we got to figure out.
3 hours long enough is my only question.
Well, I asked Chris that, and he said that's about how long North Central took. But we could. He's willing to tack on a little bit of time before or after, depending on your desires.
For what it's worth, most ACHs have done some sort of board retreat already. It's about 3-4 hours. And when you have the opportunity to get deeper into the funds flow conversation and ask many questions that maybe you never asked. So I think timing is okay.
Now you've been through some of these, have you?
One. Only one.
Was it useful?
It was very,
sure
yeah. North Sound just happened. No, North Sound was yes. And I went to Olympic, and it is very valuable. It's a realignment without the pressure of the consent agenda and then whatever technicalities we have to deal with in every board meeting.
All right. You may have opportunity to share insights that you may have drawn from other places too.
That's not a bad idea. We can, since we all are different places, we can get together and collect a few of our
take advantage of
experiences.
All that stealing shamelessly.
Fair game.
Yeah, we'll do. No, I think that might be useful.
Oh,
We approved it today, but will the next step be ready?
you mean,
There won't be anything else on the agenda for the next.
no, it would not be.
Probably the financials.
So the,
It would be part of it.
the Artemis Consulting, their actual contract wouldn't be done by next, the next meeting.
It's a good question.
It should be. Yeah, the contract, as what I'm hearing, that you guys would like to see the contract.
Correct.
But we have already approved the contract with Artemis, but you would like to see it. And if it's done before then, we can mail it out, we can email it, so.
I was just wondering if it needs to be on the agenda before all the way to May, or if there's any action item on it.
On the contract, no, I think you've approved it. I think you're just gonna see the final contract when it's done.
Okay, well, let's talk about the audit.
So the agenda looks good then? Okay, thanks.
Okay, the audit, the long awaited
audit. All year long?
2017. Yeah. Long awaited. So, you guys all have in your packet that Moss Adams wrote 2 letters to the board of directors, and one was about the financial statements that they reviewed for 2017, and then the other is about internal controls that they observed while they were in the office. So they were in the office in June of 2018, from what I understand. I wasn't there, but so the first letter is to kind of communications with those in charge with government. That is the letter that they wrote that summarizes their findings with the financials that they reviewed. And I just kind of pulled out a couple sentences. You guys can read it yourself, but I pulled out, everything was really good from what I read. So I don't know if you have a chance to read this yet, but I mean, they said things like there are no significant transactions that have been recognized in the financial statements in a different period that then when other transactions occurred, talking about the accounting practices. So that was a good statement. The financial statement disclosures, they say, are consistent, clear, and understandable, which I think they still are. But and there were no significant difficulties in performing the audit. So they encountered no significant difficulties with management and performing completing the audit. So Carol and Kylie were nice to them apparently during the audit, which I'm not surprised. There were no corrected or uncorrected misstatements. They report that there were no disagreements or arose during the course of the audit. So everything was really good as far as the financials were concerned. And then they have this book with the blue cover on it is what they actually observed and looked at and took back and took a year and a half to review and come up with this, that our financials look good.
And there was no minutes of it, right?
No. So, but the other document that they did, that they also wrote was about the internal controls that they observed while they were in the office. And so this is what I want to talk to you guys about. And then I put together, so from the Moss Adams letter about the internal controls, I put together this spreadsheet that lays out the weaknesses that they observed, their recommendations, and then the third column is what our current internal controls are, which all of them have been remedied. So that's good news. So when they do the 2018 audit, which they're working on getting that scheduled, they will actually audit on these things that they observed while they were there. And so from January to June, these internal controls weaknesses were happening. But from July to December and currently now, they have not been happening. So I just wanted you guys to see kind of a crosswalk of what they found for the internal controls and then how they were remedied after the audit was left.
And I would just add to Becky's narrative, which is really nice, is that I'd say the majority of these were because we were understaffed, and there were people that were Kylie was doing multiple things, you know, and so this was a lot happened before we had hired Diane, and we had more personnel on the ground to be able to address some of our finances. So I think it was just a matter of where we were at in growing the organization, and they recognized that. They said in a very small organization, it's not uncommon to have the same person doing many of these same things, but we have been able to remedy those things because we have segregated duties. We've hired more staff, and then we're going to be using an outside firm for some of our HR stuff. So,
and as I recall, having been on all the finance committee meetings, right?
Right.
We would talk about some of the stuff that would come up, right? And we talk about them, and then we tweak the process to try to create those segregations, or maybe create or strengthen an internal control. I remember doing that a number of times with, particularly with everybody, right? As they rolled up through the process, recognizing, and frankly, that's why we did this audit, right? That's one of the things that we wanted to accomplish was to identify what some of those weaknesses were, because we knew that they were there.
Right.
And
right. And so when I came on in July,
Yeah.
Kylie and I were able to get some of these segregations.
right,
in
you guys
place.
were able to split up.
Right.
I remember that
Yeah.
very conversation.
Yeah. So we did. So those were able to be split out, and
That's
then
good.
Yep. And then since we've brought Rachel on, we've continued that, and I think we've improved even more. So I'm pretty happy with the audit. I'm sad it took so long, but you know, now that it's tax season, they're not planning on scheduling for a month still. So our 2018 audit will.
But that is why you do the first one. First one's tough.
Yeah.
Oh,
And
it's
that's
tough.
right, and that's what they told me.
That's your roadmap.
Yeah. Yep. And Rachel and I had a meeting
That's very
with Moss Adams and went over the spreadsheet with them, and they said the same thing. They said this one was tough, the next one will be. So yeah. So we're not scared.
And I will say, just from based on experience with working with other new 501c3 organizations, this is actually a fairly short list compared to what I've seen with other groups I've been a part of. This isn't that bad.
Yeah, no,
I mean, it looks bad because you
Yeah.
have these, we're calling them weaknesses and deficiencies, but this really isn't that bad.
No.
Most of it does look like it's just growing pains.
Well, one of the other things that happens when you do these things is they go back and they review your financials too, right?
Yeah.
And so one thing to have a weakness or deficiency, it's another thing to have a weakness or deficiency with material finding.
Yeah.
We don't have any findings.
We didn't have any findings, and I don't anticipate we will.
No, you won't. So
Like I said,
that's
this is
actually,
actually not bad.
yeah, that's kind of a critical component.
Yeah, no, definitely. But because they wrote the letter to the board about the intention, I felt like I needed to, put this together and show you how we remedied that, so that I wouldn't do that huge list of all of these things. Without showing you how it's good.
Yeah, this is
That's
very nice.
good.
Yeah.
And,
So have they reviewed the new internal controls?
Yes.
Great. No, this is so nicely done. Thank you so much.
So these are all implemented and
Yeah.
operating now.
Yeah.
All of this.
Thank you.
Okay, GCACH survey results.
So we had a couple of carryover items from last month since we didn't get to it, and one of them was the findings of the CCAT evaluation. And CCACH was the independent evaluator that was hired by the Health Care Authority to look at basically 6 areas or 6 domains across all ACHs to determine how they were functioning and if they were doing the work that the Health Care Authority had envisioned them. Just right off the bat, I can tell you that the results of 2018 were better than 2017. And actually, the Leadership Council had a chance to look at this last month and even respond to some of these questions, and we just didn't have the time to bring it to the board. And they say it's not a report card. It's hard for me to really look at it as not a report card, because how else do you measure yourself except by, some of the questions that they ask you. But I think one of the things that we learned from 2017 to 2018 is it's not a good idea to send something like this out to your entire distribution list. because there were so many people on our distribution list in 2017 that did not have any affiliation really with Greater Columbia. It was people that we had snagged, and we were in such a time a time crunch, I told Megan, I said, just send it out to everyone. We were not discriminatory on who actually received the survey. This year, we were more discriminatory. The board received it, the Practice Transformation Work Group, and the LINs, and the Leadership Council. So, and we took the June meeting of the Leadership Council last year, since that was the largest gathering that we had had during the year of Leadership Council membership. And so you'll see a lot of that reflects, you know, who responded to the survey. And we actually, our board of directors, group hug, you guys outperformed in terms of your response to the GCACH evaluation. So these were the groups that received the survey. And a lot of you are involved in more than just one aspect of Greater Columbia. You're on the board, you're parts of committees, or are doing some other work. Most of you have been involved for more than 3 years, which is higher than the state average. And you report that you're very engaged, and the staff will attest to that.
I'm sorry, what is the state average?
Go back.
Oh, it's in gray.
Okay. So when they say statewide, they're measuring all of the ACHs. So statewide average was 21%. Greater Columbia is 24%.
Yeah. And we went up from.
Yeah, we went up from the last year.
Yeah.
So the next domain is functioning and impact. How can we build on our strengths and understand our opportunities for improvements, which is a nice way of saying weaknesses. The respondents' report of being satisfied or very satisfied is pretty high, with 40, 50, 77% pretty satisfied with how we're operating, which is higher than 2017. And the people that are not satisfied is greatly improved. And I attribute that to the who answered the survey. So these are the 6 domains that the GCACH graded us on: was member participation, ACH governance, community engagement, mission and goals, ACH organizational functioning, and regional health improvement projects and activities. And I'll just say right now, the spoiler alert is that we were lowest in community engagement, as were all of the ACHs across the state. I think this is a tough nut to crack. So you can see across all of the functioning domains, we rated, you know, pretty equal to the statewide average. We're a little bit ahead in some of the areas, slightly behind in organizational function, slightly ahead in mission and goals. But as you can see, community engagement is the toughest for all of the ACHs.
Is there a good definition of that engagement?
Yeah, go back to the previous slide.
Maybe because.
So here it is. So community engagement has support from key community leaders for the ACH's mission and activities, communicates effectively with the broader community about ACH mission and activities, engages the broader community with opportunities for public comment or participation, and engages ethically and racially diverse communities for ACH activities.
Yeah, and I would submit that it's still a very limited definition of engagement. I mean, it doesn't really incorporate good collaboration practice into that definition. So lots of opportunity to grow.
Yes, that's the way we see it.
So maybe we should focus on that also. Over the few months.
Yeah, and we actually, Ronnie, at the last Leadership Council meeting, when we asked some of these very questions to the Leadership Council, we had a Mentimeter.
Yeah.
And we got some really great ideas on how to address this particular area of opportunity. Some really great ideas that came through the Mentimeter. And so basically, we scored higher as an ACH across all domains from 2017. And then just some similarities and differences. all of our domains are rated higher. All the survey domains are rated higher, and we are the weakest in the community engagement. People have been more involved. I think, and then they said the only significant differences in the mission and goals domain, and that the board rated nearly all domains higher than the respondents who were not on the board, but they said that none of those differences were significant, probably because you have a closer working knowledge of what the ACH does. So they drilled down to our individual strengths and opportunities. So one of our strengths is our leadership and staff work together to further the agenda of the collective ACH, and 40% or 39% said that was outstanding. We have the leaders that bring the skills and resources that we need, and that we communicate information clearly among members to help achieve our ACH goals. For our opportunities lie, again, primarily in engagement, engaging the broader community with opportunities for public comment or participation, communicating about the broader mission of the ACH, and then agreement on how to continue regional collaboration beyond the period of the Medicaid transformation, which we will be discussing next month. Mm-hmm. And then most respondents agree that we are, contributing to the transformation of healthcare in our region. Less agreement about whether or not we're aligning resources and reducing duplication. And I think that this year will be we'll be able to attend to that a little bit more. Last year, I think we were just kind of teeing up practice transformation. We were trying to get our provider organizations into a structured process for change management. And I think this year we'll have a lot more opportunity to align resources and reduce duplication of services. And then again, just some statements that the ACH is a worthwhile use of my time. We went up in all of those particular domains. Also, those questions. So this is the third year that we have been evaluated, and this is kind of a 3-year look at how we did across that 3-year period. You can see where governance scored higher in the third year. Organizational function, again, that community engagement is just a little bit tougher nut to crack, but generally we scored higher in most all of these different areas across time, which is a good trend. And then just some feedback. Probably you recognize some of these comments. Some of you may have written some of these comments. But they said that some of our successes were engaging partners from across sectors, organization, and the region. And then comments around transformation projects, particularly bidirectional integration and practice transformation efforts. And then the suggestions for improvement was more communication and transparency. We talked about this as a staff of what we could do to improve communication, and we have some ideas about that. And then we can take those to the communications committee, which Madeline is chairing. And that, if you could scroll down just a little bit on the organizational staff. And then some comments that some people thought we were too bureaucratic in trying to reach consensus. But that's the way we roll. So I guess I'm not apologetic for that. And then again, the challenges for this year, just maintaining that level of collaboration and coordination with our partners, and then moving into action, especially with bidirectional integration. Although I think that we're doing actually very well towards bidirectional integration, and this morning was a great example of some of the kinds of integration that you can have within your practice. It doesn't necessarily just mean behavioral health, but we talked about pharmacy and housing this morning, which I thought was really, really great.
Yeah, and I thought Brian's use of the term multi-integration was really appropriate.
And I love the way that Tri-Cities Community Health is using pharmacy to, you know, gain access for the people in our community, you know, and looking at risk stratification. I thought that was really, really innovative.
They also bring in the mental health professional in their offices, in their primary care practice. When you guys were talking about that in the leadership meeting, I actually was able to experience that through my primary care provider, Dr. Marcello. And I always get the questionnaires about my gender. I always get the information of, you know, what's going on, and he's really a stickler to me staying on track with my plan. And then if there's something else that comes up, he immediately transfers me to somebody else that can care for whatever the health situation is for me. But having the blood drawn there and then the pharmacy as well, it's just been a lifesaver, because otherwise I have to drive somewhere else to get my blood drawn. If I'm fasting at the time, they can do it right then and there. There's no question about me stopping and getting a bite to eat before I end up getting my blood drawn, right? I mean, I'm serious, because these are conveniences that makes it much easier to benefit from the care that he's trying to provide me. And so all of those things really go hand in hand. And I really appreciate being a client of Dr. Marcello, being a patient of Dr. Marcello, because he tries to meet every dot on the page. So I do have to put my hands to him being able to get that done.
I also like this next comment about, you know, connecting on a larger scale. So this morning we heard from Yakima, we heard from the Tri-Cities. Martine included a blurb about, you know, Columbia County Health System. Jenna talked about Pullman. So we are trying to reach across the region to learn from one another. And I think that's really valuable when you can have that kind of peer learning. And then again, greater awareness of provider organizations and the importance of partnering with CBOs. I think Tuesday was a wonderful example of working with a different sector of organizations that we normally work with, the housing, local government, EMS, our philanthropy. I mean, there was a wide variety of people that we don't normally bring to the table at the Housing Summit. So I think we'll have more opportunity to do this year. And Ruben's worked with the local health improvement networks and getting them set up more with collective impact decision making. So I think it was a pretty positive. And then when we look at ourselves compared to the other ACHs, so it was OCH and Healthier Here that had the top scores on these graphs, and then you can see where we fall. We're the filled in dot. So kind of the middle of the road in most of the areas. And then these were the questions that we kind of asked through the Mentimeter last month. And one of the suggestions was the membership wanted to hear more about them and not us. And so that's why we tried to include some of those articles about our other partners in the newsletter today. But I think today was a great example of things that we can report out to our leadership council on some of the success stories that we're hearing from some of our partners. So we'll have probably a different look to our report in the near future. Is there anything else that you wanted to add, Wes?
That looks really good.
Was anything that surprised you in that data, that flyby?
I think it'll really go up with the community engagement this year because we're in implementation phase.
Right, and as we roll out some of these initiatives to the community health fund, to the local LINs and the TPAs, we hope to report on that, and I think that will support improvement in these areas too.
And we pretty much have a CAM presentation now on the ACH that any of you are welcome to give to your own communities and to your own sectors.
Do we have access to that?
Oh, sure. We'll send out the latest one that we did.
Well, I think of, I actually think of my own board of directors. I think it's time to kind of bring them up to speed, and that might be very helpful. Wonderful, great report. Any other comments on the GCACH report? Thank you. That was good. It does show improvement, and I think it's very positive, and I think you should consider it a report card.
Okay. Absolutely give yours yourself a hand, because I don't think any of this would have been possible without the team that they built.
Pat on the back.
Thank you.
We've got 20 minutes left, and it feels like the temperature in this room has gone up.
No, it's like really hot in here.
Don't start that now yet. I know. I'm staring right at you.
So I had to hit a 4 o'clock airport.
Yeah.
I'm
So,
paying for it now.
we have 2 items left, the community resource directory update first. So Wes and Lauren.
Lex, do you want to start?
So we haven't talked about any of this before the board yet, have we? I don't think we
Not the validation process. We were supposed to the last meeting, but ran out of time.
Yeah, so having a community resource directory is important for a lot of reasons. First of all, it's important for consumers if they're trying to find services needed and tied to the social determinants of health, such as housing, nutrition, employment, legal services, diaper banks. I mean, there's a number of different things that are important to consumers. And accordingly, there's a lot of resources that are currently available. Some of them we know about, such as Win211. There's also Aunt Bertha, which is another popular site. Alphafy, HealthBridge is another site that's being linked to the practice of the hub that was part of Project 2B, which we declined to do. There's also a lot of paper directories, at least locally. The Department of Human Services has their Red Book. Community Action Connection has their directory. Impact Compassion has their resource guide. I'm sure this is the same for some of the other counties as well. In addition, the MCOs are also doing something in this space. The Mara Group has formed a relationship with Aunt Bertha, and Community Health Plan of Washington talked about a resource directory as part of their care coordination and community linkage initiative from last year. So each of these has their own benefits and potential drawbacks. At first, we thought, let's look up with an existing one. And then we heard some consumer feedback, and so we said to ourselves, let's just go ahead and create something from scratch, which would be an additional service in the mix. So we talked to an app developer who was going to develop an app for us that was linked to Google Maps and Google Places, that would have some predefined search criteria along the lines of the list that I just mentioned. But before we did even that, we decided, let's see if we can validate a couple of things here. And one of those was what we call the back end, and the other one is what we call the front end. And the back end is that database that lies in the back. Think of a phone book, where there's a list of the resource, let's say Community Action Connections, which is down the road where our office is, the Community Action Planning Agency, and they offer a number of services such as electrical assistance, weatherization. They're part of the local coordinated entry housing program and more. So we wanted to validate a few databases. We were going to validate Win211 against Google Places, Google Maps, which is essentially the internet. And a third one was a reference directory that Sue Jetter put together for us back in 2017, which was very comprehensive. So I'll let Lauren take it from here.
You're doing so good, though. Okay, so first, I think it was in January, we started the back-end validation process. And I literally just went through Win 2-in-1 in Google Maps, and I would type in transportation. I would write down all the resources and the website and the phone number. And then I would go to Google Maps, and I would type in transportation, and I would go through the same exact process. All of this was through Yakima, so it's just focused on the Yakima area. This was included in your last board packet, so I'm sorry if you haven't had a chance to review this. But so, for example, when I typed in food to Win 2-in-1, there were several relevant resources such as People for People, Sunrise Outreach Center, Catholic Charities, and on the other end, when I type in Google Maps, restaurants mainly came up, so it might not pertain to the consumer. Material goods, I typed in to Win 2-in-1 and found several resources that would be useful to the consumer, like Salvation Army, Rod's House, Yakima Union Gospel Mission. And then Google Maps, I believe, only came up with one resource, and that was Western Materials, and that would not pertain to the consumer. So from the back-end validation process, we found that Win 2-in-1 had many, many more resources that would pertain to the consumer, whereas Google Maps was just a broad overview of all of the resources. Wes, is there anything else you would like to add to the back end?
Yeah, so the database that we used with Win 2-in-1, is Madeline still here?
Yep,
I don't think that it's been implemented quite yet. Tim Sullivan, who works directly in the space for Win 2-in-1, has done a lot to enhance that database to include more resources. So we have the privilege of being able to access that for this analysis. So that was the findings from the first part, the validation process for the back-end database. And I have to say, Lauren spent a lot of time on this, and she didn't go through it just once. She went through this process several times. The next part was a process to look at the front end. And we've talked about this before, but 1 degree has been sort of our North Star, our gold standard, as we have said in the past, in terms of the user friendliness. I don't know how else to say this, but the user friendliness of the interface that a user finds when they go online and they look at it. It's just laid out so well. It has such great functionality. It's very intuitive. It has some capabilities that few of these other resources have, such as bookmarks, creating your own profile, adding in star ratings or comments, linking in a bus map that shows where the particular resource is along a bus route, so individuals know when to get off the bus. There's just so many nice things about it. So rather than, so we started off by saying, let's take a look at all those resources in 2-in-1, which Lauren has cataloged here. You'll see on that left-hand column, these are just a listing of those resources. Some of those might not make sense based on what it says, and she can explain what they are. So we looked at that, and then we went on to 2-in-1 Connecticut. And 2-in-1 Connecticut is a real nice interface as well. And the individual states that have 2-in-1 have their own interface. We really like 2-in-1 Connecticut. 2-in-1 San Diego was also a nice interface, but we chose that in this comparison. And then we looked at, it's not really Win 2-in-1, but Win 2-in-1 we looked at specifically for Washington. And then we compared it to HealthBridge. Now, HealthBridge is a vendor that comes from CCS. CCS is the vendor that provides the Pathways Community Hub, which is the only evidence-based approach that was listed under Project 2B. So we talked with HealthBridge, have access to that site, and we listed their capabilities here. And as you can see from this nice analysis that, again, Lauren did, they by far came up the shortest in terms of the features. It means that that particular resource had that particular feature. So here, again, 1 degree comes up with the most resources, although 2-in-1 Connecticut came up with some resources that even 1 degree didn't have. Now, this isn't to say that all these resources necessarily have to be in our ultimate long-term desired community resource directory, but it's a start in terms of profiling the attributes that seem to make sense. So, is there anything else you want to add about that, Lauren?
I think just that this stemmed from Wes and I having a conversation on, okay, what exactly do we want in our ideal community resource directory? And we had an idea of what we wanted, but we didn't know what all was out there. I mean, we've looked at one degree, but we didn't compare them when we started talking about this. So I think this just gives us a better idea to see what each domain has, what it has to offer, and then bring it forward to everyone else to see, okay, what's most important out of this list? What do we really want in our ideal community resource directory?
You know, as we said, this is something that could potentially be used by consumers, but it's also something that will facilitate linkages and referrals between provider organizations, social service organizations. So there's a lot of usefulness for this type of tool, right?
Yes, I'm listening to John saying that from perspective of being user friendly and actually building this to where users would find a resource that they needed that could help others that's not listed in that app, where it can be defined for those for upgrading new resources. So it's like people helping people. So I found this resource kind of cool, and then the app would upload that into its system, so it with keywords that would be able to help others find a resource that they were seeking out.
Yeah, so in terms of apps in general, at first we thought it would be desirable to have an app that everybody could load onto either a mobile device or a pad or even a desktop. And then we sort of backed away from that idea, simply because it adds a whole other layer of technology. So I think our focus was on something that would just be a site that you could go to. And this analysis doesn't take into consideration some of the other services that are offered, in particular by Win211, which are very important, which include operator assistance. A lot of people don't want to go onto a smartphone, they just want to talk to somebody and find out what resources are available. This analysis does not take that into consideration. I don't know if I answered your question.
Probably not, but it is what it is. There's a lot of people, I'm sorry.
Go ahead, Ronnie.
There's a lot of people that have a lot of information that they hold. And I've seen it come out in layers of whether you're Facebooking, I need information for this or for that. But a lot of people are technologically these days.
Right.
And when people want to talk to somebody, they call they call the 211 operator.
Right.
When they're tech savvy, they go on Facebook and say, hey, I'm looking for recommendations. If they're in a situation that created a deficit or a disparity for them, they go to those groups that other people are at, like you had mentioned, Impact Compassion Center. There was a temporary group put together for 2019 snow helpers. And that just listed a whole bunch of people helping other people.
Yeah, I mean, it would be great to have one end-all resource, and I don't think we'll ever achieve that.
So why are we reinventing a wheel?
Well,
That's the question.
so let me go ahead and have Rhonda, you have a question?
Well, I have a question, and I guess I should have a question and a comment. Number one is you're for today's purposes, you're telling us the process you're going through. You're not looking for any recommendation or anything. It's for today. Is that correct?
We're informing the board about the work that has happened, and we're actually going to make a recommendation about how to go forward.
Okay. So my comment is from a provider standpoint. And one who participates in 211, we get annual requests to update our information. I can't imagine doing that twice. And so I'm not sure what your thought process is, but I probably won't do that twice. And most organizations probably won't do that for two different databases. So I don't know if you're thinking that this could be, if you're using providers have invested a lot of time inputting their information and trying to keep it current. And I know for their, I shouldn't say this, I'm sorry.
No.
But for their accreditation purposes, they are required, and, you know, if I don't do it, I start getting calls from their staff saying, we haven't seen your updates this year. Sure. So there's a lot of motivation for me to get them to stop calling me. Update. So I think that's a consideration.
Okay. Anybody else have any comments before I talk some more?
And notice the time.
Yeah.
We have
5 minutes.
All right. The last agenda item can wait.
Okay.
That's something I'm going to present on.
All right.
So I guess there are other organizations that put this together. And one of the ones we use in schools a lot is the Red Book.
Right, which comes from the Department of Human
Human
Services. Right.
So, I mean, there's a lot of different databases. I think that if you could figure out how to use that for whatever that by whatever, we were talking about from Microsoft, and just see if you can tie the databases together and create a super search, you could probably do a great job. I mean, I don't know. I know that's kind of a pipe dream, but.
Yeah, so we had a conversation earlier about some technology that could play a role down the road, but for right now it's probably too much. So I will tell you that we did think about, you know, the issues of trying to do something from scratch, DIY. And with that, we've also had several conversations with Tim Sullivan and Madeline and Joyce, and what we tentatively agreed to is to work with 211 going forward. They're working with a developer named Site Savvy, and given the information that Lauren has compiled through her analysis, what we would like to do is see if we can influence the process of updating their user interface, their web interface. And our support would be perhaps through some technical assistance based on our findings, and the support might also come financially as well to help them develop this in a way that frankly we see as being more optimal than what currently might be available. So that's the recommendation. I also want to say that what we would like to do is to loop the LINs into this process. Joyce has already visited the LINs at some of their meetings, and we would like that process to continue so they can feed into that back-end database, because nobody understands what's on the ground better than the people who are on the ground using the service. So by participating in the LIN meetings, it might be a way for her to catch additional resources that might not already be included into their existing database. So that's our recommendation going forward. We don't have specifics about, to be honest, how that relationship will look, the contract arrangements, the funding levels. I do have some money in my IT budget that I can put forward to this. That's what we would like to see. Anybody else have any questions about that?
Like you put a lot of work in it. A lot of sleuthing.
And one thing Wes didn't say is that I think they've done so much work on this, Lauren and Wes. This would be a proposal that maybe all the ACHs could get behind. Because you know that there are some ACHs that are already using 211, Washington, 211. And if we could all pull our resources and just conversation on, is there anything in this particular, I stepped out for a second, but I think that public transit feature is extremely important to our clientele. Maybe there's just a few things that we could add on to, you know, what an already great database that would make it a little bit more functional.
So why was something out being considered again?
It's just the technical nature of developing an app, and I'm not saying we're ruling out an app. We just made it less of a priority than we originally did.
Everybody's still app.
It's a potential. Again, it'll add to the cost and the timeline of development.
But working with 211 would also give you an app. 211 has an app.
Yeah.
So you'd be able, if that's the route that we ultimately go down, that's something that we can help enhance, is that app.
So we've downloaded their existing app, and I'll be honest, there's a lot of opportunity for improvement.
Right.
So,
But if that were to become something that collectively across the state, the ACH has worked on, or even if it's just us, there's a lot of improvements that can be had there. So would still technically be an app.
You've made a recommendation, but it feels like you don't need a motion to keep doing the work that you're doing at this point.
Right, I think at some point, I don't think the size of this potential contract is going to be huge, but we can bring this back into the form of an SBAR.
That'd be great. Okay, good report, thank you. Okay, well, you do have 1 minute left. Do you want to say that? You want to say that?
It's something that, believe me, is not time sensitive. It's a report we can bring back to subsequent meetings.
Okay, so we do have 1 minute left. Does anyone have any announcements or updates they would like to share in the final minute? Going once?
All right.
Twice? No.
I got one.
It wasn't a challenge day.
Dan's been quiet all afternoon, so you get the final minute.
So Lauren's going to be sending out information around the Sentinel Network, and it's data collection for workforce needs and demand across the state. ACH Greater Columbia has been fabulous in responding to requests to be Sentinels in the past, and we continue to be leads. Healthy Here kind of jumped ahead of us a little bit this last round, and so just be looking in your communications with more about requests to be Sentinels, which is also going to be highlighted at the World Health Conference next week.
Great.
Great.
Thank you.
We are 5 seconds over. Because it was Dan, we're not going to penalize him. So do I have a motion to adjourn?
Yes. Second.
Moved by Ronnie, second by Sandra. Any objections? We are adjourned.
You need a motion?
Thank you.
You need a motion to adjourn?
We had a finding in a bureau site visit once because our minutes didn't show the motion.
Oh my God.
I didn't realize that. I didn't think you needed a motion.
It could have been the reviewer.
Okay.